Overall, this is the most common indoor allergen. We all have them. In patients with upper airway disease, it's not infrequent that at nighttime, first thing in the morning, they have significant congestion, a lot of mucus accumulation, and it gets better over the daytime because you're breathing it in all night long. It's a perennial allergen, but there are seasonal increases in the summer and fall. They grow best with moderate temperatures and they like humid environments, which we're going to go into with humidifiers. And there are two major species in the U.S., Dermatophagoides farinae and Dermatophagoides ternicinus. The major allergen is contained in the fecal pellets. They're large particles. They're not airborne. Things like HEPA filters do absolutely nothing for controlling dust mite allergen. They settle very quickly after you vacuum or sweep. They grow best in fabric, so mattresses, pillows, stuffed animals, upholstered furniture, that's where the dust mites are and where the problems are. And again, we focus on the bed mostly because you're lying there for 8-10 hours a day, as opposed to your upholstered furniture or carpeting where you're not spending so much time. The first line of control, and I think in all cases there has to be some reasonable approach to this. Mattress and pillow encasement, so you're wrapping the pillow and mattress to control dust mite release. You're washing bed linens every 1 week preferably, and it has to be hot water to really get rid of the dust mites. You remove stuffed toys, you vacuum, you keep things clear. Control humidity, so in some cases you need dehumidifiers. We discourage humidifiers. Again, dust mites like humidity. They also like, mold likes the humidity as well. And in these patients with chronic respiratory symptoms, it can be problematic. Asthma education far and away is the key to success to the treatment of these patients. I'm not going through the medications, but things that are important in regular follow-ups are to review the asthma signs and symptoms. It's amazing how many patients don't understand what it is that they use, what symptoms will lead them to treat with albuterol. So you need to go over that. What are the expectations of asthma treatment? And really, we're looking to decrease the frequency and severity of exacerbations. What medications are you prescribing, and how do you administer them? Do they have spacer devices to make sure the medications are getting to the airways? Do they know how to use them? Is the device you're prescribing appropriate for this particular child based on their age and their abilities to actually do some of the maneuvers that we require? All these patients with persistent asthma should have asthma action plans. The family should be empowered and know what to do in what situations. It also forces us to be particular in terms of thinking through sort of the logic in treating this. Some patients benefit from peak flow meters, and you go over environmental control measures that are based on the particular child that you're treating. So question one, a 2-year-old boy has had 3 wheezing episodes over the past 12 months. Risk factors for progression to wheezing in school-age years include A, eczema, wheezing not associated with upper respiratory tract infection symptoms, mother with a history of asthma, child with allergic rhinitis, or all of the above. So all of the above, and this comes from the Asthma Predictive Index, which is an important thing to keep in mind. In the very young children with wheezing, we're always trying to sort out whether this is a child who's going to have virally induced wheezing and it's going to go away, or is this a child that's going to have problems as they go on and we need to treat it very aggressively. In the Asthma Predictive Index applies to children less than 3 years of age with frequent wheezing, so at least 3 episodes of wheezing in the first 3 years of life. And it's broken down to major and minor criteria. The major criteria is the child has eczema. Keep in mind, the more severe the eczema, the more significant this becomes. A doctor diagnosed asthma in a parent. So if one of those major criteria is true, you have a positive index. Minor criteria, physician diagnosed allergic rhinitis. So it's not just that they have runny noses when they're in daycare, but they truly have environmental allergen sensitivity. Wheezing apart from cold, so they wheeze, they have no evidence whatsoever of a viral upper respiratory tract infection. And in those patients where you have a CBC, eosinophilia greater than 4%. If you have 2 of the minor criteria, positive index. What's important, a positive index, there's a 77% positive predictive value that child is going to have wheezing in school age years. If it's negative, it's about 95% negative predictive value. So, what it's doing is it's trying to identify that subset of young children that are going to have problems as they get older, and all of these are based on evidence of atopic disease. Question 2, a 12-year-old with allergic rhinitis has persistent nasal congestion. She has had little relief from loratadine or Claritin. She's most likely to benefit from the use of oral pseudoephedrine, oral cetirizine, intranasal budesonide, intranasal ipratropium bromide, or intranasal cromolyn. Intranasal budesonide, so in this patient, the only thing that helps with nasal congestion are nasal steroids. Decongestants can help, but they're problematic for long-term treatment. So with allergic rhinitis, again, the underlying problem is you generate IgE antibody against things you shouldn't: pollens, dust mites, pets, cockroaches. The differential diagnosis in these patients that come in with chronic upper airway disease includes allergic rhinitis, which we'll go over in detail, and it can be seasonal or perennial. Many patients have perennial symptoms with seasonal exacerbations, and it's based on their underlying sensitivities. Infectious etiologies, such as chronic sinusitis, recurrent upper respiratory tract infections, virally mediated. Anatomical abnormalities. A lot of the young kids that I see that come in for allergy evaluation have large adenoids. And there's also non-allergic rhinitis, where they have the typical features, they respond to the same medications, but when you test them for environmental allergen sensitivity, they have negative testing. And these patients, if you look at their nasal smears, they have eosinophils just like allergic rhinitis patients. The prevalence of allergic rhinitis is about 20%. It's rising. This is very common. In seasonal allergic rhinitis, patients typically develop rhinorrhea and nasal pruritus. Their nose is incredibly itchy in those seasons when they're having problems.